I'm just Hannan, GP here. Margaret, are you able to turn around, or do you want to turn around? This is Margaret. We've heard about other people in the community. Now, Margaret, I hope you don't mind.
I do, but
I won't say who Margaret is. Or do you want to say who you are? And how you've turned up?
Sorry.
How have you come today? What happened?
My daughter saw me today. As you can see, I can't walk. So I brought my fever. I don't.
Do you want to say a little bit about how you attended at being here? What happened?
My mum was ill on Monday and we had to call the doctor out. She's living in Grange at the moment, in Central Hyde. And that's how we got to be here today when we're speaking to you. She's on medication now, which is a good thing. And we're hoping all's going to be well at the end of it all.
So she's in a residential home, and I went out on a visit, and I happened to see her, and her daughter was there with me. We did the medical bit, and then as I went outside, I was thinking about today's meeting and thinking about responsible sharing, and thinking about, well, would you like to come along and be here, because you're one of our patients as well. And her daughter very kindly agreed. She's brought her here today, so thank you very much for coming. And I'm going to talk briefly about responsible sharing. Hopefully. Maybe not. Because actually, we start to wonder what's all this about? Who is the NHS for? Why are we here? And so I'd like to start by thinking about the constitution of the NHS. And in particular, I want to remind ourselves that the NHS isn't for doctors, it's not for nurses, managers, senior people or whatever. It's not run in London or even in central Manchester. It belongs to the people, you and I and everybody. It's there to improve our health and well-being, supporting us. This is the Constitution. The Constitution is saying it's about supporting us, not doing things to us. To keep mentally and physically well, to get better when we are ill, to stay as well as we can be, and to the end of our lives, wherever it might be. It works at the limits of science, bringing the highest levels of human knowledge and skill, and to save lives and improve health. It touches our lives at times of basic human need, when care and compassion are what matters most. And it's been an absolute honour to listen to all those people. I don't know what you are all going to say, but I think you've just demonstrated what the NHS is about and how it is for the people, by the people, and for everyone. But actually, me as a GP, where I work, it's in my little consulting room. This is where the consultation that I had when I went out to see Margaret. It was a very, very quick, maybe 5 or 10 minutes or so. And during that consultation, I'm getting some idea of what the problem is, trying to understand what we can do to try and help, and trying to bring the best that medicine can offer and support. And now we're beginning to realise that many of the problems that we have are not actually medical. They're social, they're psychological, and lots of other issues as well. So we're now starting to think about, in the way that John, you were saying, that actually medicine can't fix it all. And we need to start to think outside the box. And there's a little bit about education, there's a little bit about some of the services that exist out there in the community. But actually the decision making around the behaviour change, what I've seen, happens in that 10 minutes. You might be a person, but when you come into that consulting room and you sit down as a patient, you're in a different mode. You're sitting there, you're thinking about what, and actually what we're trying to do is something called shared decision making, where we're trying to work out what is it that we need to do within healthcare, what is it that you can do. If you can't do it, can your family help you and other people and start to support each other? Now, you're trusting me to deliver the best that medicine can offer. We're trusting you to do the best that you can do and help us what problems you've got. But actually, if we take this information that's on that computer system, and it might be your electronic health record, but it might well be the services. I noticed, Warren, earlier you were typing in Hyde Community Action as you were listening, and he was scanning in and looking at what sorts of services are available. Why did you do that? Because we've got this thing called the internet. You can be anywhere you are, and you can start to access information. You can start to link up what you can do with what's available there. And if we turn that information around, so it's not just the doctor or the nurse that sees it, we can also, we move into somewhere very exciting called the Partnership of Trust. Now, we started doing this 13 years ago, and this is our latest figures from this week. And as you can see, overall, we've got 12,117 patients. 60% of our patient population has got access to their full GP electronic health record. Another statistic, today I did my surgery this morning, every single patient that I either spoke to or saw already has access to their medical records. They've already done it, which means that whatever consultation I have, when I hit the file button, they can then go online, they can view that record, they can see what's being discussed, they can check that what we've agreed has actually been written down as such, because if they're not happy about something, they can come back to us and say, actually, I'm not sure about that. And you can see that our patient population starts from 0 right through to 90 plus. Our oldest patient is 103 years old. And you can see that it's starting to flatten out in terms of males and females. It used to be lots of females that were signing up, but now we've got males as well. And if we look at it slightly differently in terms of types of patients, overall it's 60% of our patient population. But if you look at asthma, it's 67%, diabetes 62%, cancer 60%, depression and anxiety, it used to say 99%, we had a data issue and I've now realised. Come back to that in a moment. 72% carers, pregnant women 93%, learning disability. In the country at this moment in time, only about 1% of the population has got access to some part of the record. And yet in this practice, 42% of our patients with learning disability have got access. If you're Bengali, you're more likely to have signed up than if you're English white middle class. What's going on there? Why? How? But now I want to move to something else that I think is really important for us to start to understand. Because what we're now beginning to realise is that oftentimes, and we heard a couple of stories where the mother didn't have the information when she turned to A&E, and we're starting to realise that if we really want to improve the quality of our services, we're going to have to start to share information. And some of that sharing has already started. So I mentioned that we've got an extended access clinic that we have in evenings and weekends. We've got 3 hubs, one here in Hyde, one in Ashton and one in Glossop. And for patients who can't get an appointment during the daytime or who are working, they can get appointments in the evening and weekends. And in order to book into that appointment, you have to speak to your own receptionist and say, can I have an evening appointment or a weekend appointment? They ask for consent. They say, is it okay for that doctor, that nurse, that pharmacist, that healthcare assistant to access your medical records? That's where you get the consent. That's then recorded. And then when you come to the clinic, the clinician can then access the medical record. It's not the whole record. There are parts of the record that they can't see, but it's most of it. If you turn up at the urgent care centre, at GoToDoc, they can also access part of the record. It's not quite the same as the full record, but it's partially there. And then if you've got end-of-life care and you need to contact the district nurses or the Macmillan nurses, again, or if you call the ambulance crews, and you're on an end-of-life care pathway, that's immediately prioritised, so that suddenly you're not sitting waiting for hours. We can try and get you the care that you need. And this is all really important stuff. A&E, if you go to casualty, we've got the summary care record that they can access, which is again a partial part of the record, and there's plans for you to be able to access a little bit more of that medical record. So those things are already here now, and these are available, and those are parts of your record that is now being accessible outside from the GP practice. And it starts with this question where the clinician asks you, would you mind if I look at your electronic health record? Now that's okay, but the trouble is if you've not seen it yourself, then how are you going to know whether it's okay or not? And if there's issues around quality and data and safety and things, there's a bit of a problem there. However, that's what happens at the moment. And there are plans to go further than that. So we're going to have something called the extensivist service that the CCG is working on at the moment and the local ICFT are dealing with. And what we're doing there is we've identified the top 10% of patients, would that be right? Yeah, top 10% of patients who are at high risk of being admitted into hospital or being needing to be referred into the urgent care service or whatever, and thinking about how can we proactively help this group of patients and get the support for them before they roll up in hospital. And that's the next plan. And then the thing is, of course, in order for those clinicians to be able to do that, they're going to need access to the records. And the question is, how do we go about doing that? And we go beyond that because there's now talk about taking that data, putting it into a machine and starting to look at artificial intelligence and finding patterns and things that we haven't picked up on before. This is all great stuff, and I think it's very, very exciting. It's coming. Much of this is already here now. But the question is, this is all about sharing. How do we make that responsible? How do we make it so that each and every one of you, as patients, are happy that this data is being shared? And me as a data controller, as the GP that's holding that record, are happy that you're happy that I'm doing what I should be doing and not just enabling information to be made available to anybody without your consent. So I think we need to start thinking about responsible sharing and not just sharing. And what that means is at the same time as enabling the services to access the records which they need to deliver their care, we also give each and every one of you and your loved ones and your carers and anyone else that you're happy about access to your own personal medical record. And that starts by providing you with an explicit consent questionnaire, which means that you've got some understanding of what it is that you're signing up for, what are the benefits and what are potentially some of the risks. And then once it's been vouched for and checked by the practice to make sure it's okay for you to access that information, we make it readily available for you so that you can see it. And here are 2 apps that are already available now that you can use. One is the patient access one, which has been around for a long time, and the other one is Evergreen, which has just recently started. And that
1 more minute.
1 more minute. Okay, I'll be done in 1 minute. Okay. Because you've then looked at your record, when you're then asked, would you mind if I look at your record when you turn up at A&E or whatever, because you've already seen it, you've got some idea of what's required, so that you can then quite happily say, yes, I want the ambulance crews, I want the extensivist, I want the urgent care doctor to be able to see it. And my feeling is responsible sharing is not just about enabling the services to access the records, but putting the same amount of effort, if not more, into also enabling you to be able to do that. So, what's it about? Well, we need to get the information governance right. And we're working on that within GM and of course across Thames and Glossop. I think that consent process where patients and carers have some understanding of what it is they're signing up for is really important. We've done our questionnaire for 13 years now, it works really well and you can see the numbers. I think it's not just about accessing your records, but it's gaining an understanding of what that means and how it can help you to drive your care, which means increasing the capacity and capability, not just of patients, but also for practices to understand how to support you. And that enables engagement of all stakeholders so that you're not left behind. We need to be working together. It's lovely to see patients, members of the public, senior clinicians and managers all in the same room, all thinking about how can we do this. Try to manage expectations because we can't do it all at once. And finally, by enabling that, knowledge saves lives. Thank you very much.
Brilliant.